thank you for the very considerable effort you put into your witness statement. It was incredibly comprehensive, so it will be a great way for us to start having a conversation having read that. So we really do appreciate it. So I did notice in your witness statement you started with your experience and reflections in terms of the changes you think are required to the mental health system, and then you talked about your own personal experiences. Are you comfortable if we reverse the order today and you tell me about your personal journey and then how that's helped you in terms of the role that you've been playing in trying to improve the system?
Absolutely, that's fine.
Yeah, okay, so let's do that. And it's with all these conversations, it's really powerful because it grounds very much your experience. But before we do that, I was conscious you gave emphasis to the importance of language. So before we start and talk about your journey, do you want to just give me a bit of an understanding of why you think language is so important?
Sure, and thank you for asking. It's a topic that we consumers or survivors have spoken about a lot for decades now. And it's partly about how we conceive of our experiences. And so I'm one of those people, I don't view my experiences as being a mental illness or a problem with my brain or my biology, but actually being a response to social experiences. Also, our language is often tied to having had pretty awful experiences in the system. And so being referred to as a consumer can be tricky because, you know, I didn't choose to consume the service most of the time. I was, you know, forcibly detained and locked up. And so I prefer to refer to myself as a survivor of trauma, of coercive health services. But people do have really different preferences. So I just wanted to point to that in my statement, and I've done my best to be respectful of many different points of view.
Yes, and I think that, I mean, it is really important, and I was certainly very familiar with the language around survivors, but more from the broader, as you said, family violence, sexual assault, the broader fields of the in the child and family welfare service system and the like, not so much associated with mental health. So it's been really interesting to read how you had seen that being both a consumer survivor. So I thought that was really important. And also your preference to not use the term, notwithstanding that is a term we grapple with a lot at the Royal Commission to decide we would use. But yes, I appreciate your preference to not do that personally.
Thank you. But I'm also, I like to view myself as a pragmatic revolutionary. I'm committed to change, but sometimes you just got to have a conversation where we all know what we're talking about too. So
absolutely. I like that term. Hopefully, I think I'm probably a bit of a pragmatic revolutionary too in some ways, so it's a good term. So if you go back and we started, and it was, I know telling these personal journeys is often very challenging for people, and I really do appreciate how much effort you did to put your experience in context for us. So if you start in terms of your complex trauma history, which I think you've described very well in your witness statement, but can you just summarise for me what that is in your mind?
Of the trauma history prior to mental health system, sure. So I experienced trauma from quite a young age in sort of three different ways. And so those experiences of multiple traumas are often referred to as complex trauma. So I experienced physical abuse and neglect from my primary caregiver, my mum, from a pretty early age. I like to recognise as well, I think it's important to recognise that she was a trauma survivor herself, and that really there was a process of intergenerational trauma going on there, which is difficult, that she could not really speak about, and she couldn't access help during her life either, which makes me very sad. I'm hopeful that we can stop doing this to families and people. But that was very difficult. And I also experienced anti-Semitic bullying. I was raised Jewish up until the age of 12. And when some of the local kids found out, I was beaten up a number of times. I ended up changing schools twice and stepping away from my family's faith because I was so frightened by that experience. So it's a pretty significant effect. But probably the headline trauma for me in terms of what stuck with me over the years was that when I was 13, I decided to run away from home for probably some self-evident reasons I've already described. And on the first day, an older man found me and suggested I go back with him to one of the regional towns so the police wouldn't get me. And, you know, for years, from 13 until 40, I never knew what to call this experience, but he kept me in a house. It was a broken down old farmhouse. There were no floorboards through most of the property. There were dead rabbits everywhere. It was cold and scary. And he kept me there for 2 weeks, and I was sexually assaulted. And I don't think, it's probably not helpful to go into lots and lots of detail around that, but it was, you know, there was processes that I came to see 27 years later as a whole lot of grooming and abuse. But I think the kicker from that experience was that I never told another living soul about what happened. The police didn't seem, you know, this was the 80s, but no excuse. The police didn't seem to pick up that there was a situation of abuse going on there. My mother also told me never to say what happened, which, you know, in these later years leads me to think she must have known what had actually gone on. But I don't know. Perhaps she couldn't hear it. Perhaps it was too much to hear that had happened to her daughter. And so I never spoke about it, and I had to make sense of it.
It was a very powerful, I think the way you described in your witness statement, your mum's own experience of not having disclosed her being having another child until she was dying, and, you know, the trauma associated with that and the silence around it for whatever reasons that she felt, and then your own silence about not being able to disclose or deal with that sexual abuse. It's something, you know, so powerful for so many people, the detrimental impact that silence has in terms of people's sense of worth and well-being. And I think you really talked about that so strongly, about feeling it must be something shameful because no one wanted you to talk about it.
Absolutely. And I think my mum was ashamed of what happened to her. When she spoke about, you know, and she had no choice in the 60s. She was forced to adopt her child, and there was no option for a teenage girl back then. But she was deeply ashamed, and I guess that was the message I got, to be ashamed as well. It's also the social message that's given to so many girls and women, to be ashamed of things that are done to us by perpetrators, where of course the shame doesn't belong to us, it belongs to the people who hurt us. And
yeah, so I think that was very powerful, the way you conveyed that. And it is pretty challenging, you know, even then, well, as you said, it was the 80s, you know, the fact that the police didn't think, hey, there's something unusual here, a 13-year-old girl and an older person in those circumstances. But, you know, that whole impact of sexual assault that we know now has such profound impacts on people. And clearly that was something, it was a long time. You said until you were 40 before you disclosed that to anybody.
Yep, absolutely. And I was somewhat comforted, saddened, but a bit comforted or validated when I read in the other big Royal Commission into institutional child sexual abuse, that I believe the average age of disclosure there for institutional abuse was 23 years. So it makes a lot of sense. And it really underpins, which you know, we'll be getting to, I'm sure, why the issues I experienced in the mental health system were so particularly not okay.
Yes, and I guess it was what you also, before we get onto that, you also said you were punished for running away. So that lack of understanding about why might you run away? What is it that would drive you to doing something like that, that also then placed you at risk in a different way in terms of the experience, I think.
Yeah, absolutely. And there were all, we wouldn't have time today to go into the detail of that, but there are a whole myriad of ways in which I was punished for that and internalised that punishment, and really couldn't make sense at such a young age of why this has happened, of why I felt the way that I did.
And so I guess you then move on to say, and in your 20s you had this outward impression of a very successful, capable, highly functioning person. So can you just talk a little bit about that? Because clearly you moved beyond that and were having these amazing experiences in your early 20s.
Yeah, yeah, it's an interesting time to look back on. It feels like I was another person. I I had quite a mixed life in my late teens and my early 20s, where I was became very determined to just to be good, which to me meant and to my family meant, academic success and getting a good job, all that sort of outwardly respectable stuff. But secretly was always still struggling in various ways, and sort of playing out what had happened to me in some pretty tricky ways in my personal relationships and in my intimate life during that time. So I worked, I studied business at university, graduated with distinction. I went on to work at one of the big, at a big organisation, and worked my way up. I was a junior executive by the time that I left. But I would do things like when I was waiting to cross the street and I'd see a bus coming, I'd think, shall I step in front of that? Maybe I'll step in front of that. These were the thoughts that I would have that became increasingly tricky and would have been, and were at that time initially viewed as depression. It was more complex than that, but
yeah. And I think you summed that up really well by saying it got harder and harder to hold it together. That sense you were holding this complicated set of things together, and you described how hard that was to do that over time. And then by the time you were 30, you had actually been formally diagnosed. Yeah.
Yes. That's right. It's
yeah, suppressing or repressing things is a useful defence strategy, but I think it only works for so long. You can only hold that stuff down for so long. And it actually just got more complicated and painful while I was pushing it down. So yeah, I got diagnosed with depression,
and I stepped away from my my corporate role. I went to art school because I didn't quite understand what was happening to me. I wasn't really connecting the two things, the trauma and how I was feeling, because I hadn't made sense of it. I'd never even spoken about it. But I thought maybe, if I pursue a creative path, I'll find a way to be happy, but that didn't work very well. And I ended up making an attempt on my life and began my experience as a mental health consumer or survivor.
And you said that was a pretty difficult 9-year journey that you described before you saw yourself as a survivor. So clearly, having variable diagnoses, and I think you say, being told very pessimistically. In one paragraph, you talked about the diagnosis of schizophrenia and how pessimistically that was framed. And other consumers have also told us that, how devastating it was to have a diagnosis like that, because it wasn't framed in that time as being hopeful. It was framed as being a really pessimistic thing. Can you talk a little bit about that? Because that's a very powerful thing that you explained in your witness statement.
Sure. So the diagnosis, I got 8 or 9 diagnoses in the end of my journey. It's like swap cards, but nowhere near as fun to collect. Although I shouldn't joke about it because it wasn't actually funny. But when I got the schizophrenia diagnosis, I remember a psychiatrist sitting down with me and telling me I needed to accept that I had a disease in my brain, a chemical imbalance, that I would have to take medication for the rest of my life. And I had to be realistic about my future. I would probably never work again, but they'd help me to get onto the disability pension. And, it's, I believed that, at the time I was not, I believe, as most people would, this was a specialist medical professional telling me that my brain was diseased. And I just thought, well, it's all over. Who I was and what I've dreamed of for my future are all gone. And so I lived down to that message for a really long time, believing it, until I realised that actually it was nonsense and an incredibly damaging and irresponsible thing to say to someone.
And I think that you talk about that did start this journey of multiple hospitalisations and presentations to EDs, but that whole thing about being on a disability support pension and thinking that is your future, and the impact of the medications that you're on, having to see that to stay, what a difficult issue that was too, in terms of whether the medication was actually helping you.
Yeah.
Mm.
Yeah. It's so I in the early days took my medication. I thought the diagnoses were true, the medication would help and all of that. But what I came to see over time is that they weren't helping me at all. And I had, aside from clozapine, I reckon I've tried almost all of them. I've had so many antidepressants, antipsychotics, mood stabilizers, benzos. I had a period where I was quite inappropriately coerced to get antipsychotics injected at my GP every 2 weeks. And the effect for me was gross sedation, being absolutely zombified, which lots of people use that term because I think it feels so true. My emotions were strange and dull. I couldn't think properly. I felt stupid. I felt it was so hard to form thoughts. I became morbidly obese, and yet I remember in the early days being told that a side effect is that I might gain a bit of weight. And I often comment on that and go, I don't think 50 kilograms is a bit in anyone's definition. And we need to be honest about these effects. If nothing else, we need to be honest about the adverse effects. But also that, the research tells us around these medications that they've got pretty variable effects. So absolutely, some people will find medication really helpful, and that's great. I was not one of those. There are many people who don't find them helpful at all. And there are also people, I guess, kind of in the middle who will say the medication's helpful, but only insofar as it suppresses everything, but it suppresses the good stuff as well as the bad stuff. And to me, that's exactly, the medication did exactly the strategy that society did to me after the abuse. The service never asked me about trauma in 9 years, never asked what might have happened to me to bring me to this place. And, society, my family, the police, society suppressed my truth with shame and silence. And effectively, mental health services did the same by never asking and by treating me with things that suppress all of my experiences.
And do you think it was because the focus was on the diagnosis? So is that because you described that, and the impact of the medication was so powerful, and you described that so well, and we have heard that from so many people, and it's just so shocking that in our modern era we still have medications that have such terrible side effects for people. But in terms of why there was no asking of you how you might have got there, do you think that was linked to the variable diagnoses that you had?
No, look, I think I'd love to come back to that medication effects again in a second too, but I'd explain it slightly differently. It's I'm aware not everyone holds this view, but I'm aware that a great many people share the view that I have, which is that for a great majority of people who attract a psychiatric diagnosis, what we're in effect doing is medicalising or pathologising a life experience. And so for me, the experience was complex trauma as a child, and the distress was associated with that. And I can speak with a lot of confidence that was absolutely the issue, not depression or schizophrenia or any of the other labels, because when I finally was able to address the trauma, here I am. I'm working. One of my jobs was a senior advisor to the chief psychiatrist of Victoria. So I know that was the problem because I addressed it. I've never touched a mental health service since. And that is a not uncommon experience for a lot of people. And so I would suggest that we have a system, and in particular because we don't have a comprehensive, compassionate trauma system, that if people are distressed, they end up in the mental health system or the drug and alcohol system, or maybe the justice system, because we don't respond to trauma. Where is the trauma system that responds to comprehensively to people who've experienced family violence and child abuse and refugee trauma and homophobia and racism and all of these things. It's not really, there's tiny slivers of it, but it's not there. So we get funneled here. Depending on how we express our distress, we're given a label. And the treatment is almost entirely medications and electroconvulsive therapy. And I've had that as well. It's not like TV. There's not therapists sitting, therapy doesn't happen during inpatient admissions. It's purely about assess, diagnose, medicate when we seem to be more stable, discharge.
Yes.
That's it.
You talked about just one point, and I'm happy to go back to the medication issue raised, but you also talked about the fact that you said it was not entirely voluntary in terms of some of the treatment interventions. So describing your fortnightly depot injections was, you said, was do this, take this medication, or you'll be subject to potentially a community treatment order. Was that, so it was either if you don't comply, we could use compulsory powers to make it?
Yes, it was. So say yes, or we'll force you to do it. And I wish, back then I was still learning about, I didn't even know there was a Mental Health Act really back then. And so I didn't realise, if something like that happened to me today, I would say, well, have a go at putting me on a treatment order, but I will get an advocate and a lawyer to contest it. And actually I'd have access to more things to help me if I had pushed back. But I didn't know that. And, we have in Victoria incredibly high rates of compulsory treatment. I think disturbing. I mean, I would get rid of compulsory treatment altogether, unquestionably. I understand that many people will tell you that we should have it, but I'm someone who'll tell you a system that is there to care, that works mostly with trauma survivors, should not ever use force. But even if I've lost the train of my original thought there.
But that was really, you were talking about that was there when you had to take the depot injections. But I think that is, you then talk about, though, the fact that in this journey you were on, you then lost any sense of hope, I guess, is what you were saying. You started to self-harm and have very strong suicidal ideations. So in terms of that period, I guess that you went to a very low place in terms of your treatment journey in this course. So do you want to just speak briefly to that, and then we could go on, and the obviously the ECT, that was the part of that journey too.
Sure. So I did use self-injury for about 4 years of my life. I used self-injury for about 3 years and then stopped, and then came back to it again later. It was another thing that I didn't really understand at the time why I was doing it. I, like many people who self-injure, and that attracted me an extra diagnosis on top, which was borderline personality disorder. So you almost invariably get that label if you use self-injury, which was not helpful, because that attracted labels like, oh, you're just doing that to seek attention, or you're doing that to be manipulative, some quite unpleasant stuff really that's inappropriate. And so experiences with that were pretty awful. There was one time I was stitched up in an emergency department, and the doctor said to me, I'm not going to waste local anaesthetic on you because you obviously like pain, which shows to me that person had no understanding whatsoever of self-injury and how it works. And it was excruciatingly painful, but even worse than the physical pain was feeling that I was less than human.
Yes.
Really.
Yes, that was a very sad thing to read, that in your statement. But I guess you then go on to make the point that no one ever asked you about the cause of your distress and the level of those distress, and how you had to make sense of what had happened to you. And so what did really, you talked about the fact then you got on this journey of, I guess, discovery and personal recovery. Can you tell me a bit about what made that happen? What was the thing that moved you from that circumstance you were in into a different perspective?
Sure. I think there were kind of two stages. The first stage for me kind of led into the things that we mean when we speak about recovery-oriented practice, without doing any deeper healing with the trauma. And that was a community worker, so not at a clinical service, who helped me to find hope. Phenomenal worker who eventually became my manager and then just a great mate, and someone I've looked up to for a long time, was just stubbornly determined not to give up on me, and stuck by me for about 9 months before I could even begin to think about the future. Sometimes I wonder if it's just because she was Scottish and she was just that determination to never give up. Was wonderful, and she worked with me in lots of creative ways. That was incredible because my hope was gone, and I think that is absolutely a foundation. But it's quite realistic in this world, I think, for many of us not to have hope. So there was that, and the other part of that was learning some coping skills, and that enabled me to get off all of the medication, which was wonderful. It didn't, the weird thing with coping, I was very grateful for it. It took a few years before I came across that, is that I use this sort of analogy where I say, the madness or distress was kind of like drowning in the middle of an ocean. And medication was kind of like this life jacket that the psychiatrist threw down from the rescue chopper way up here with all the power. And they said, put it on and it'll keep you alive. And maybe that, we know that happens for some people, but for me, the life jacket didn't work. Sometimes they're faulty or they're busted or it's the wrong size for you. It didn't keep me afloat. But coping skills was learning how to tread water on my own. And there was a whole lot of, hundreds of different things that I brought into my life that helped me to cope with the distress. They didn't take the distress away, but I could live with it on my own without attempting suicide, without self-injury. And those things enabled me to actually go to work again. And that's when I began working in the mental health sector. To take back some more control. So that was the first bit. That was important. But what happened was about 5 years after those things, I'd been increasingly learning more about mental health and listening to consumer activists and survivor activists and speakers. And I'd come across the Hearing Voices movement, and I realised that that all the people speaking there with lived experience had gotten to somewhere so much better than where I have. They weren't just sort of hanging on to life that was really, really hard and exhausting, that they didn't hate themselves the way that I really hated myself. The voice I used to hear would tell me, well, I can't tell you a whole lot because it's probably, the words would be too rude to have in a royal commission. But
I can imagine some of that.
Imagine. Insert some of the really nasty things that I might have been told. But part of that was hard for me to comprehend as well. My voice told me that I was a rapist. And that the world had to be protected from me. And there were periods when I was super distressed where I believed there was this kind of evil being living inside me and that I needed to protect the world from it. And I recognised that would have sounded incredibly strange to other people. But in the Hearing Voices approach, which is an approach with support groups and therapy approaches, it's sort of co-produced by psychiatrists actually based in the Netherlands and increasingly around the world, and consumers working together, which is quite nice, is this recognition that those experiences are meaningful, and that rather than suppressing them with medication or distraction, that we can actually go deeper into them. And so for me, the metaphor for that was actually diving into the experience and making sense of it so that I was no longer drowning. And that really worked for me. And so that involved me actually engaging with my voice and saying, okay, so if I'm so evil, if I'm so terrible, what are my actual crimes? There was an activity I took myself through once that was, I wouldn't recommend people do it on their own. It was a hell of a night, but in one night I kind of put myself on trial. And I said, so what's my crime? But the person who'd suggested I do this said, if I'm going to prosecute myself, I have to also be a sort of defence barrister as well for myself. So I sort of drew out of my voice, you know, if what is it exactly that I've done that makes me so awful? And as I did that, all of the trauma stuff came out. It's your fault because you chose to run away.
Yes.
It's your fault because you didn't actually say the words no.
Yes.
It's your fault because you were a very grown-up 13-year-old and you should have known better. And there were all these layers of stuff. And what I eventually did was get on to, I tried to do some therapy with a private CBT therapist, and it didn't work terribly well. I look back and think this person wasn't trained in trauma. He just went straight into tell me your story without any preparatory work. And so I ended up with another hospital admission, and the psychiatrist said, so obviously I disclosed trauma then, and she said to me, you just have to forget it. It's in your past. I've spoken to your psychologist and told him not to speak to you about your childhood again. So no more therapy, and we're going to put you back on medication, and you just need to forget it. So that was awful. That particular experience actually almost finished me off, because 27 years of work to try and get to therapy, and then it was shut down, and I was terrified of being put on a community treatment order. And so I lied my way out of it. I got some amazing support, so I won't go into that, but that really helped me to do that. And I've got to tell you, Penny, I know so many other survivors who've done the same thing. Where I said to my psychiatrist, not straight away, but I said, look, I think maybe the medication's starting to help. I did a fake recovery plan with all the things I was going to do. I asked them to help me with some strategies to remember taking my pills when I had absolutely no intention whatsoever of taking them, until they discharged me, because they thought I was doing wonderfully well. And then I went to the Centres Against Sexual Assault.
So perhaps before we get to that, because that was obviously a big turning point, but I thought it was really, you said that you started on this journey of your recovery, if we want to call that work, as being a survivor, when you met a mentor who was really important to you, someone who gave you a sense of hope. You started learning some coping skills, and yes, there were some challenges, and you went back into hospital, obviously, but you also talked about that meeting this Dr. Rufus May, who was there from the UK. Was that just by chance? Because it sounds like that was pretty amazing, that opportunity to meet that person. Was that just someone who visited while you were there?
It was very lucky. I often think I've been so lucky in my recovery and healing journey, and I wish everyone else could be. So I was working, at the time I was program manager of Voices Vic, which is the Hearing Voices Network for Victoria. So it was a primarily peer delivered service, but we had one, we used to jokingly say our token normal worker as well, who didn't have a lived experience but was wonderful. And so we'd actually paid to bring Rufus out to Australia to run a training course as part of the work that we did. And so when my colleague went to pick Rufus up at the airport, I'd been, and it wasn't by choice, I'd been compulsorily detained at hospital. And so my colleague told Rufus that Indigo sends her love, but she can't be here. She's locked up in hospital. And Rufus, being an immensely generous soul, said, well, let's go straight to the hospital then. I want to go visit Indigo. So
amazing.
It was incredible. And so I tell you, I got changed out of my daggy hospital pajamas pretty damn quick.
You say in your witness statement that your hope returned when you were showed some compassion for yourself and encouraged to do that, and notwithstanding that you described that you lied to be discharged and not put on the order, you did say that that was one of the things that allowed you to have a sense of hope. And then you contacted the CASA in terms of your healing journey about your sexual assault. So that was obviously when you started to frame it in terms of you being a victim and your trauma being very much related to your mental health. So can you speak a bit about that? Because that was obviously very profound for you.
For sure. I've actually got quite a long blog post that I've written about this encounter with Rufus, and there were a couple of things so he only sat with me for about 2 hours. I often hear that people can't do therapy when they're in hospital or psychotic, but I'm living proof that actually we can. And there were two things. One was that I was talking about my voice and what the voice had been saying to me. I used to call this voice the judge. And Rufus expressed compassion for my voice. He said, God, he's got a pretty tough job, doesn't it? It sounds like he's just has to keep an eye on everything and do everything possible to keep you well. I wonder how he feels about that. And then he sort of pondered and said, I wonder if, we could come up with someone to job share with him. So he didn't have to do all of this on his own to keep an eye over you. And of course, that voice for me was, it was an inner critic, really, that was out of control and that was driven by shame. And so the first activity I got out of that with Rufus was to come up with creating a second voice. So quite obviously I didn't tell my psychiatrist that I was trying to create a second voice because she would have been quite alarmed by that. But I did. It was just an imaginary exercise that I did over and over. And so I came up with actually a figure from television from my childhood that I loved. And it was kind of a sort of proxy mum figure for me. When I was little, it was Mrs. Ingalls from Little House on the Prairie, which shows my age.
I do know who you're talking about.
So it's just like, Mrs. Ingalls is the best, Mum. And so every time my voice would say something awful to me, I was walking around with this big sheet. I can remember it's yellow paper. It was the only paper they had in the art room at the time, which was quite annoying. And I would write down what my voice said, which assumed it was some terrible judgment about me. And then I would say to myself, Mrs. Ingalls, what do you think about that? And I didn't hear her like a voice, but I knew because I grew up with that character what Mrs. Ingalls would say, and it was very different. She would say, well, look, I don't like us using that kind of language around here. And I think that's not very fair. And really that simple little activity, what it did, of course, was just open up my own compassion for myself. And so every time I heard something awful from myself, I had a really creative way that engaged with the reality of what I was living with to respond with compassion rather than give in to the shame.
And then you talk about that journey, then recognising the trauma. And I guess you then do talk about having become involved with the Centre Against Sexual Assault, and that probably leads us into now your very strong views and advocacy around trauma-informed, and I'll come back to that because language is important here in your statement too. But that was obviously very important in terms of getting you to where you are now, reconciling that you were a victim and a survivor of trauma. So can you just talk a little bit about the role the CASA played to that, and then we'll go away from your personal story into how you're now sharing that insight you've got for the work you're doing?
Sure. CASA, and I should say as well before I lead into it that I do know quite a number of consumers or survivors who've not had positive experiences with CASA. I was lucky that I had a wonderful experience there, and I think that makes sense to me because there's this great gulf really, but I think between a service like CASA and the mental health system, and there's knowledge there missing about some of our unusual experiences, and I feel like a great mass of knowledge the mental health system is missing. But I saw a counsellor who used used a sort of feminist approach to therapy, and also some quite creative ways of working with me, and it was as well as a healing journey, it was also an incredible learning journey. So that was where I got to speak about what had happened to me, which I had been doing prior to going there a few times, but not very successfully. But she helped me find the words to describe it. And so she was the first person to say to me, there are names for that, and would call what happened to you abduction. Yeah. And I argued horribly and said, but I wasn't tied up and thrown in a car and driven away. He asked me to go and I went. And I had to learn that, well, he was an adult and you're a child and he took you away, and that is abduction. and rape and child abuse. And so that was just, having those words in my mouth felt strange. And she helped me to understand how shame works, but also grooming. For me, the two most powerful things were understanding grooming and understanding Stockholm syndrome. Because as I came to understand those, it made so much sense. I couldn't understand regardless of what everyone said to me, why didn't I speak out? Why did I have these really conflicted feelings about what had happened? And as I understood grooming and Stockholm syndrome, of course, it made sense. And I learned about how common my feelings and reactions were amongst many survivors of family violence and child abuse. And so it was really freeing. And my counsellor said that I could still take legal action. I could still file a police report if I wanted to, that I could try and access victims of crime compensation. And I chose not to pursue those paths because sadly, I think our justice system fails survivors of sexual violence as much as our mental health system does. And I didn't want to expose myself to more trauma, frankly.
And I think you summarised it really well then when you say my recovery, like most, has not been a cure. But it's actually creating a life worth living and that you value. And I think it was very powerful. So when we go on to that now and think about the role that you're playing and the things that you think are important for the mental health system to respond to, you give a great deal of attention and some really useful analysis to this issue of trauma and trauma-informed practice. And I'm trying to find it where in your statement you talk about that. But it's I found this description here about your approach and to the focus in the trauma literature on recovery and what that means. And the difference about that, you summarised it really well, because when I first talked about what is the trauma-informed approaches in mental health, I realised, it took me a while to realise exactly what you explained. It was totally different to what I'd thought of in my previous child protection and related background, And so, hello, Kat.
I'm sorry. I knew he'd turn up sooner or later.
I'll be there. Let's go here. Give me some attention. So I think that recovery, it was a really different meaning of recovery. So do you want to just talk to that a little bit? Because it is very different, isn't it? The two, how you reconcile the mental health view of recovery and the abuse survivor sense of recovery.
Yeah, look, and I think it's complex because in consumers and survivors before me campaigned long and hard for recovery-oriented practice in mental health, and I'm a very big supporter of recovery-oriented practice. We don't have it, by the way, although lots of people will tell you that we do. We don't even measure it, so I'm not sure how anyone could claim that we have it. But recovery-oriented practice is about having a great life regardless of how much distress you might be living in, because that's had historically been ignored for consumers and survivors throughout history. And so it's my favourite study about recovery is the CHIME study that I've referenced in my statement. I think because it's grounded in a whole lot of other lived experience narratives. And so that's about having connectedness, being connected in the world, hope,
Yes.
A sense of identity beyond being a psychiatric patient or a person with schizophrenia, because that's a very limited and untrue identity. But that was my identity, along with the identity of feeling that I was a bad person. It's about meaning, and I think in the literature, but also in lived experience, people speak about meaning in two different ways. One is that sense of a meaningful life in terms of employment and a home and friendships and relationships. But the other aspect of meaning is making sense of what this distress is all about, making meaning from the experience. And then finally, empowerment, which is not something that we can be given. So lots of people in their statements from the sector have told you how they like to empower consumers, but actually people can't empower us, but they can let go of their own power and support us to grab hold of power and empower ourselves. And so that's the notion of recovery, and it sits apart from what's going on with our distress, because the idea is that they're the ingredients that lead to a great life, and we can have a great life even with distress. And I think even before I tackled trauma, I was experiencing quite a number of those aspects of recovery. So that's sort of recovery, but that's been developed in relation to the mental health sector, which has largely ignored trauma. Yeah. So if you go over here and look at the trauma literature, and I reckon lots of people would think that the mental health sector is full of people who are specialists in trauma, and because I often come up with people who seem quite surprised when I say no, that it's really not, but it's really not. And I encourage you all, if you're able to dig into that and find evidence that people are trained in trauma and tackle it, because I've never seen it. And so in the literature around trauma, which tends to be grounded more in therapy and counselling, speaking about recovery, there is more what clinical recovery means in mental health. It's about reducing distress.
Yes, and remission of symptoms, was the way you described that in terms of the approach there had been.
Yeah, and so I'm probably obviously not a fan of language like remission of symptoms, because it's commonly used, but because I don't view my experiences as symptoms of illness, but as
on mute, Indigo.
Yeah, the cat actually did that. So
no hanging outside, so between us. So let's go. Well, your cat's very good, computer literate.
He is.
I think that was a really important thing, though, that you talked about. The recovery-oriented practice in mental health was very different from trauma-informed recovery. And so I think that was the two paradigms are not the same, so we don't assume they're the same thing.
No, we need both. We need a focus on trauma, and we need a focus on recovery. And the focus on trauma is actually is bringing a different way of understanding our experiences, and supporting us to heal from the trauma. And it begins with naming it and supporting disclosure, and then providing supports that are related to trauma, not just symptoms of illness. You're on mute, Penny.
No, I'm block the noise out from outside. So you also said, though, even though in 2011 you say that the Victorian framework for recovery-oriented practice was developed in mental health and was a priority in the 10-year plan, but you do say you don't believe it was effectively implemented. Do you want to talk a little bit about that? And then I want to go back to this issue of trauma and recovery too.
Sure. Well, it was implemented in the way that many reforms in mental health are, which is with documentation and short training courses. And I have to say, I've not seen that ever lead to any deep or sustainable change. There are no key performance indicators or standardised measures for recovery-oriented practice. I recall sitting once with a senior clinician who said to me, I'd been speaking about recovery, and he said something like, "Oh, as if we don't do that." And I said, "How can you say that? We have a framework, we have policy advice to do this." And he said, "We don't take it seriously because we know the government doesn't take it seriously. If it was serious, there'd be a KPI for it, and there's not." And I thought, that tells me a lot. We shouldn't need to have a KPI for everything that's good practice, but perhaps for things that challenge the dominant paradigm, we really do. And the other thing that tells me we don't have it is, well, there's two things. One is, I know absolutely from my own experience, there was no focus made on any of those things. But it is our annual reports from DHHS have a section that's supposed to report on outcome measures for recovery-oriented practice and trauma-informed practice. But what's actually reported is what's called HONOS measures, health of the nation outcome something. Sorry, it's in my paper. Everyone, Scale.
Yeah.
Yes, which has nothing whatsoever to do with recovery-oriented practice or trauma-informed practice. And so...
You would then also go on, though, to describe really about why you think the mental health system is actually challenged to provide a whole-of-life approach in recovery and to adopt that more trauma-informed approach to recovery. And in your statement, you talk about what some of those challenges are. Do you want to just speak a little bit about why it's challenging in mental health to take that broader approach?
Sure, there are so many challenges. I'll see how I do. I think one of the most fundamental challenges is the education of mental health clinicians. Trauma is not well addressed in that space, and I think that alone would be an important and substantive project to actually assess what's happening in undergraduate and postgraduate education for mental health clinicians in relation to trauma, and perhaps do a comparison with what's expected and required for staff at places like Foundation House and CASA, because there would have to be an enormous gap. So the education's not there, but the processes are also not there. So the mental health system, the acute system, is based on getting us in there. We're assessed, which means we're observed and interviewed. We're given a diagnosis, and then we're given pills, or medications and/or ECT, electroconvulsive therapy. And when it's observed that we seem to be less at risk to ourselves or others, which is a whole other problem, because risk assessments are drive a lot of the mental health sector. But there's no particular strong evidence that they have any predictive value. Lots of people put great faith in them and take away our freedoms based on them, and yet they're not necessarily predictive of anything. And the chief psychiatrist himself ran a whole forum on that matter with guest speakers to address it. So
yes, we had a session on compulsory treatment this morning, and that issue was raised. But then one of the other points you raised, and you just compared it with the trauma recovery model and training that somewhere like Foundation House does. We had a visit to Foundation House, and they also talk about how long it can take, how long the journey of engagement might need to be with an individual for them to recover from those experiences. And the mental health system, in terms of setting up that therapeutic relationship that will allow someone to work through that, seems to be pretty challenging in terms of providing for that. And I liked your approach with the 4 R's, but how realistic do you think it is that we can have a mental health system that can allow for that sort of therapeutic intervention and recovery and healing process?
my advice will be at the more cynical end of advice that you get from people, or the more critical end. I believe that we could significantly reduce the harms that are done to people, that the additional traumas that come from forced treatment, restraint, and all the rest of it, and being told, having your experiences suppressed. We could reduce that harm. We could make it more therapeutic. I think ultimately it's not fit for purpose for people who've experienced trauma, and where their distress is primarily related to trauma. I don't think it makes sense to have a workforce that's primarily doctors and nurses, that's based in hospitals, that's related to legislation that involves the use of more traumatising approaches. And in my statement, I speak about how a service can be trauma creating, trauma neutral, trauma informed, which means, you're thinking about it, but it's not your main gig, or your trauma specialist. And the mental health system at the moment is trauma creating. It creates a whole lot of traumas for people and doesn't do anything specifically about trauma. And what we need is a trauma specialist system right up the other end. So I don't think it's realistic for any system to move from one extreme to another. And so I think, with my idealistic hat on, to me the ultimate, the best response to that is to create a better trauma system, so that people bypass the mental health system altogether and go to services that are grounded in peer support, counselling and therapy, rather than hospital-based services that are grounded in medical approaches, and that we actually enrich the trauma sector with more spaces and more openness to address complex trauma that might come from many different sources. I recognise that suggestion involves a great many millions and millions and millions of dollars. But what I'd say in response is think about the cost of me going through the clinical mental health system, where it's over $1,000 a day for 9 years. I had a go once at trying to work out how much I would have cost government, and I got to over $400,000 for all my hospital costs and Medicare costs and pension and ambulances and EDs. Whereas I may be unusual, but for me, less than a year of support around the Hearing Voices approach and CASA counselling, and I didn't need support again. And so I did get more intensive support, but it was over a much shorter length of time. And I guarantee, from a system point of view, the costs would have been much cheaper. You know, hospital admissions are enormously expensive. And I don't think, I feel strange saying this because the government's budget is not really my concern or interest, but the government is not getting value for money from the mental health system at all.
I think you summarised your distinction between trauma-informed and the need to prevent further trauma in the mental health system, and then also needing to access trauma specialist services, in your view, to recover from trauma and to heal. And I guess that's a really interesting challenge for us in terms of thinking through the models. Can you do both in the same settings, or what needs to be that balance? But you're clearly saying that from your point of view, it's the healing power of a trauma-informed specialist trauma service. I think that's really clearly what I took from reading it. In the end, you've said, you know, you've looked at what it would take to introduce that across the mental health system. And I think in one stage you estimate 5-10 years to embed a cultural change that you think would be needed. And I read in your statement, you ultimately conclude that you think it's better to create some of these specialist facilities. Is that right?
Yeah, that is right. I think it's probably the only realistic approach that could work. At the same time, though, I'm be a huge supporter of reforming what we currently have in the acute mental health system, and with particularly in terms of reducing harms. And so I'm sure you've read in my statement a whole raft of suggestions of ways to reduce the traumatic impact of mental health legislation. And there's a number of issues that we don't legislate for, either like chemical restraint. It's not even defined or monitored, and yet it happens all the time in every mental health service. So there's a great many things we could do to reduce harms. I also speak about rethinking the workforce balance that we have in the clinical mental health system, and so we can and we should train up the current clinical workforce in trauma. And well beyond short courses and deep into people's qualifications. But there's a question for me as well around, do you try and bring people who don't understand trauma up to a high level, or do you bring in people who are already skilled at trauma and flood the sector with some different workforces who actually specialise in these areas? And I think, you know, there's an argument for all of those things.
And I think that is maybe not either or, and it's about have we got that balance. You also talk very powerfully in your statement about the causing of more trauma and, in your view, the need to eliminate forms of restraint and those things that are re-triggering for people who've experienced trauma. So that would be a priority from your type of point of view to even, if not eliminate it, minimise it in terms of the trauma creating element of the current system?
I would absolutely believe that we need to eliminate all restrictive practices, and not just for trauma survivors, because if you haven't had a history of trauma, you're very likely to have one by the time you've been locked in, held down, you know, strapped down. So solitary confinement, it's called seclusion in mental health, but it is in essence solitary confinement, can be a really terrifying experience. I was locked in a seclusion room after a suicide attempt. And I wrote about that in my statement as well. And I sat in there punching myself in the head. So, you know, I wasn't made safe. And actually what I just needed was someone to sit next to me and say, what's going on? Why did you do that? Oh, you're on.
I found your suggestions about what we can do very helpful and very thoughtful for us to consider in terms of it. So I'll be certainly talking with the other commissioners about your witness statement and things that you think are important in terms of changing the mental health system's response, that workforce balance that you talk about. But you then do talk about some new type of trauma specialist services that you think are important to be created, and what role consumer survivors should have in that. And you point out you think they're different from what we've recommended in our peri-pono type facilities. So can you just make sure I have an understanding of what you think is going to be important if we were to go down this path of any trauma specialist services?
Sure. Yeah. So what's you know, it was great to see a recommendation for lived experience delivered service in the interim report, and that's quite different to a lived experience run service, because in that space we actually, you know, consumers or people with consumer survivor experience form the governance, the management, and the staff. Some of the other differences as well in a peer service is that people are trained in peer support, which is a discipline all of its own, whereas a lived experience delivered service, you might have nurses who are working as in the nursing discipline but also have a lived experience, which means that the practice that you experience, what's provided, would be quite different. And the other big difference for me rests in the governance and organisations' views about risk. And so when I think about when I managed Voices Vic, which was sat under Param Mission Uniting Care, well, I'm not sure, I think I wasn't supposed to name organisations. Anyway, you can bleep me. It's good stuff. It was a beautiful program, I think, and we worked with people who heard voices. So mostly been diagnosed with schizophrenia or psychosis. Mostly people who went to the local hospital service and had for many years. And we supported people to find ways to live with their voices and to reduce the stress from them, usually through exploring past trauma, but also engaging with their voices and changing the relationship, a bit like I described. But there were lots of different strategies. And that approach, I think, would be viewed as risky by the average hospital, that they would be concerned about, you know, someone like me who's been diagnosed with schizophrenia, talking with someone about listening to their voice and talking about past trauma, and what might that mean. Our mental health system is absolutely driven by risk and concern about risk, to the extent that risk management creates one of the biggest issues of all. You know, that is actually the risk, is too much risk management. It's wrapped around on itself. And so I think a lot of innovative lived experience or peer work practice wouldn't be permitted if an organisation sits under the governance of a hospital-based service. It's just too foreign to how they work.
Thank you. That's helpful for you to clarify. You also gave some examples of where you think there have been some good peer-run services, and we're always keen to have a look at some examples. And you said there were some in the US, but I was also interested in your notion of recovery camps. And you said there were some camps like this run in Australia as well as overseas. Are you able to point us, not now necessarily, but it would be very helpful to give us some ideas of where the Commission could look for those sort of concepts?
Sure, absolutely. I'll send through some more information, and it's a nice, it's a sort of different spin really on thinking about, you know, hospitals are a kind of residential, you know, admission type approach, but having shorter experiences where you come together and can actually do some quite intensive healing and recovery work in that kind of environment. That's a very different model to what we currently have, and also creates a lot more flexibility.
given the time limitations we have, and I've already run us over time, so forgive me, but it was, I think it does.
Penny Armytage, you're being non-compliant, which is a good thing.
Chris and Phil will be going, what's she doing? No, anyway, but I think it does show how fulsome your witness statement was and how many issues there are in it to give us food for further thought in terms of what we're grappling with the Commission. But is there any final message you want to give me and hence us about your reflections about what you think is important in us designing the work for the mental health system of the future that will better deal with trauma? Is there any final message you think you want to make sure I'm clear about?
I'll sneak in two because I'm always cheeky, and one is that is to try as much as you can to hold on to the idea that it's not a pathology. It doesn't have to be an illness to experience distress. I understand that's so different, so very, very different to what the mental health system does and speaks about, but that actually it can be really helpful and healing to see that our experiences are normal and what's happened to us is the abnormal and scary thing. And to work with people from that point of view can be incredible. And the other thing I'd say is that, this may be inappropriate or unfair, or wrong, but in my mind, I think Australia doesn't do a great job of human rights and doing right by people. And I think mental health services, the clinical part of the system, sits very squarely in that space when we speak about offshore detention for refugees, and we think about youth justice, and we think about so many terrible things that have been done in the, to Aboriginal and Torres Strait Islander people, that mental health services are the other space where we detain people against their will, where we strip away personhood and can do terrible harms behind closed doors. And so anything that we can do to increase human rights, even if it may not seem like it, that will actually bring us closer to respecting trauma and not making things worse for people.
Thank you very much for that, Indigo, and thank you, as I said at the beginning, for so much thought that you put into your statement. Being prepared to share your personal journey grounds our reflections in the experience of consumers, survivors, in terms of what they think is so important in our redesigned system of the future. And as I said, your very many suggestions of ways that things can be improved, and also your evolving thinking, where you've gone and you're trying to understand what would be the best way for the system to work going forward. So it's been fabulous to have the chance to have this discussion with you. Thank you very much for your time. And hopefully we'll have an opportunity to have some further discussions as we refine our thinking down the track. So thank you very much.